Hello and welcome to the Clinical Care Options podcast. I'm your host, Zachary Schwartz. In this series, we explore challenging cases in primary biliary cholangitis. And in this episode, we look at how to assess the symptoms of PBC and how new therapies may help alleviate the burden of symptoms such as pruritus. I'm joined again by Dr. Alan Bonder from Harvard Medical School in Boston and Dr. Aparna Goel from Stanford University in Palo Alto, California. To download slides you can use to follow along with this podcast, visit clinicaloptions.com or go to the show notes for this episode. Now let's get started and hear from our faculty.
Welcome, everyone. This is Curbside Consults, specifically evaluating and managing PBC symptoms. I am Dr. Alan Bonder. I am an associate professor of medicine at Harvard Medical School and the medical director of liver transplant. And I am here with Dr. Aparna Goel. Hi, Aparna.
Hi, Alan. I'm Aparna. I'm an associate professor at Stanford University with an interest in autoimmune liver diseases.
Well, let's just start with this patient case. We have a 40-year-old female with PBC that was diagnosed 2 years ago. Her main kind of symptoms are pruritus and fatigue. She also complained of sicker symptoms, so she does reveal that she has dry eyes and dry mouth. And she has been receiving, for the last 2 years, a properly dose-weight-related UDCA. When we look at her blood work, we see that her bilirubin is normal. Her AST and ALT are within normal limits. Her alkaline phosphatase is 190. She has normal bile acids. She has a normal elastography of 5.5 kilopascals. And she has a normal liver ultrasound with a normal spleen and normal liver size. So when we look at PBC treatment goals, we can look at two main goals. The first one is disease progression. We would like to get those patients treated so we can get their numbers better to prevent advanced fibrosis or cirrhosis, liver decompensation, the need for liver transplantation, or any episode or any event that will cause a liver-related death. But also our goals should include symptom-based therapies because we need to try to achieve or improve quality of life. And in those symptoms specifically, we will go over about pruritus and fatigue. We know that the symptoms of PBC significantly impair quality of life and do not typically improve with treatment. Therefore, they warrant separate evaluation and treatment. So, Dr. Goel, what do you do on a regular basis when patients come into your clinic? How do you assess for symptoms in those patients to come in with a diagnosis of PBC?
Yeah, I think that we understand so much more now how prevalent pruritus is in our PBC patients. It affects about 70 to 80% of our patients. And we historically have such a short period of time to talk to our patients. So it's hard to evaluate at every visit, but I try at the very least to just ask about it. Are you experiencing itch? If you are experiencing any itchiness, does it prevent you from sleeping? Does it affect your day-to-day quality of life? Are you using anything, any medications or any ointments, anything to help you with these symptoms? So, that took me probably about 30 seconds. And that's all you really need to do to start that initial conversation, I feel like, to get a sense of the degree of itch they might be experiencing. And if you need to spend more time to understand it and to intervene upon it. So itch severity varies from very mild itch and to very severe pruritus, where patients come in with excoriation marks and, are causing themselves to bleed in the middle of the night. So it's really important that we spend some time evaluating it at each of our visits and effectively treating it. We're the doctors that are able to do that. So we owe it to them to do that.
Oh, and I know you mentioned about questioning and asking the patient, but some patients really don't feel they need to open to their physicians because of the stigma of itching. Have you used any other type of tools that will help you to get that answer out of those patients? For example, I've been really kind of using the electronic medical records in advance. Have you used any other tools that help you to go into this?
I have a lot of patients that have participated in clinical trials for PBC. And as part of trials, there's often significant surveys or a fair number of surveys that patients answer to understand the degree and the quality of their itch. So there's several different scales that are used. I, in practice, have not been able to implement anything in my electronic medical record, but I wish that there was a way to do that. What I am planning to do, what I hope to do, is at least give some sort of a visual analog scale or some sort of a scale and offer it to my patients in the clinic so that they can tell me from a scale of 0 to 5, how bad is this? And that way I can understand how much time I really need to spend addressing it.
Thank you. And I think itching is really highly prevalent, affects up to 81%. can occur at any age, at any time. So it's not a linear symptom, so it can appear at any time of their disease. We basically know that's an undervalued. People with PBC reported no discussion of symptoms with their providers. We know it's underappreciated. And finally, we are not doing a good job treating this symptom that can affect their quality of life. So we know that people with PBC and clinically significant itch have never received the proper treatment to relieve those kind of symptoms. So I think, as Dr. Goel said, there's different tools out there. These tools have been used mostly in the clinical trials, but this is the tools that work for both of us in clinics. We have what's called the visual analog scale, where you show this to the patient and you go from no itching 0 to 10, and the patient can basically, with their finger, point exactly where they feel they have their itching. This actually rates their itching from the last 24 hours. And then what we've seen is the scores of 4 to 6 is kind of the score when we think about they have moderate itching. And when their score is 7 to 8, there's severe itching. Most of the clinical studies have really included patients with moderate kind of itching, which is in the 4 to 5 range. So how do we recommend assessing this kind of bothersome symptom? So I think, as Dr. Goel would say, is at every visit, we need to spend some time with patients about this. A kind of keyword questions that she used: are you experiencing any itching? If the patient answers yes, there should be a follow-up question. How is that affecting your quality of life? For example, is it affecting your sleep? Is it affecting your day-to-day activities? Are you afraid of going outside because of the burden of seeing itching? All those questions should follow that yes, and then really did not take really a lot of time. And then based on this, we really can consider the patient's a scale, and then we can really start therapies right away. So Dr. Goel, is there anything else besides this type of questions that you would use, or do you think this is really a good start to assess itching in patients with PBC?
I think that as broad as possible and a way to get your answers, in a succinct way is great. The only other question that I sometimes ask my female patients with PBC predominantly affects women, but are they changing the clothes that they're wearing because of their itch? Just because sometimes tighter clothes, or patients prefer to wear loose fitting clothes if they're very itchy. So I'll sometimes ask if they have changed their wardrobe around so that they itch a little bit less. A lot of people start to, I think, normalize it, or start to just make their own lifestyle changes to deal with the symptoms because they don't feel like anyone can help them out. So if we kind of dig a little bit deeper, we can see if they've sort of accommodated their life in a certain way to deal with this symptom.
And I think that's so important, because I think even just how patient report their itch verbally may also be different than what we really is recorded. For example, that patient can say it's not severe, but then when you ask her specifically all those symptoms, she's not able to sleep, she's not able to do, or basically daily, things of living, and then she's basically scratching. So I think also getting this objective data really helps us to guide the treatment options for the future. So let's just start with, how do we manage itching? So this really takes us to one of the very important key elements of itching or symptom-based therapies in PBC. A lot of patients really kind of focus on their biochemistries, right? So the question is biochemical response correlates with symptoms improvement? And I want to say the response is absolutely not. So there is a lot of patients who, despite having normal alkaline phosphatase, they still really itch significantly. This is one study that restricted to people with moderate to severe pruritus. Up to a quarter of those patients had normal alkaline phosphatase. You can see what the AASLD guideline says, that PBC-associated pruritus does not typically improve with first-line PBC therapy. And this is really, really important. We do get to see a lot of patients referred to us with the proper dose of UTCA, and they're really expecting that UTCA will be the therapy of choice for the symptoms, and we need to explain that to patients. And finally, we need to make sure that we address symptoms. We need to assess for itching, we need to assess for fatigue, so pruritus warrants separate evaluations and treatments.
So the itch from PBC can occur at any time since their diagnosis. It doesn't necessarily, if you don't have it at the time of diagnosis, doesn't mean it won't develop. So people of any age at any time since their diagnosis can experience daily itch. And again, as you have so clearly laid out, the itch severity doesn't correlate with laboratory values. So it's very important to assess it separately.
So let's just start with the non-pharmacologic treatments that we can both recommend really as look like common sense. We look at topical moisturizers. I mean, I live in Boston. I don't think Dr. Goel has the cold weather, but that's something that we need to address. Cold showers. We recommend fragrance-free soaps and laundry detergents that are really not very irritated to the skin. And as she said, clothes is really important. So avoidance of irritating fabrics, tight clothes is something that we would recommend to kind of improve her itching. That Dr. Goldo, I'm missing anything that you would use as kind of like regular measures to actually improve itching.
Yeah, these are great toolbox for non-pharmacologic therapies. That's usually where we start, or especially for the patients that have mild itch.
And let's just spend kind of a few moments about what is the American Society of Study Liver Disease recommends to treat itching. And let's just start with first-line therapy. So bile acid resin, specifically cholestyramine. So personally, I'm not a believer. I'm not really kind of feel that this really helps. So, but I'm going to ask your opinion. Do you really use a lot of resins in those patients?
I will try it, but the tolerance is so poor that very few patients can tolerate it. And the other complicating thing is just the dosing schedule. You really have to space them apart from other medications, especially the ursodiol, if they're on that too, to make sure it doesn't prevent the absorption of ursodiol. So it can be quite challenging for patients to use. So I've had very little success with it, but I do still try it. I haven't fully given up on it yet, but I think that there might be better options coming.
And then we go to kind of the second line. And I think from the second line therapy I think my favorite is rifampin. I use it with really good success. So twice a day medication, there is this fear about this causing liver toxicity, but as liver doctors, we really advise on these patients to get monitored. I've used naltrexone with kind of just not as the same response as rifampin. Sertraline is also one of those kind of weak SSRIs. But again, in your opinion, do you share my kind of personal thoughts, or do you have any other preference in these three drugs to use for itching?
Yeah, I totally agree with you that this is where our backbone really is for pruritus management. I agree rifampin can be incredibly effective for cholestatic pruritus. I don't use it if the bilirubin level is over 2.5, 3, and I don't start it in those patients. But if it's less than that, I will start it and I'll monitor that on therapy.
And then finally, other options that are there, phenobarbital, not really kind of broadly used. Plasmapheresis, I've used in one or two patients in my 15 years of practice. They are the MARS, the nasobiliary drainage, UV light, and topical therapy. Again, this is not kind of standard therapy that we use, but again, some patients who we have exhausted every single option, we can look to see if they actually can help. But really want to stress kind of the UDCA does not really affect, itching. So it is so important to make the point that UDCA should not be used as a first-line therapy to treat itching, as same as the kind of the disease, as a disease-modifying medication. So making the point again, since first-line treatments do not prove pruritus, is there any kind of data showing from the second-line therapies? But the FXR agonist kind of well-known side effect is pruritus. So if you have a patient who has itching, OCA should not be the first therapy to be used in those type of patients. And then finally, we have elafibranor or seladelpar. So in both studies demonstrated potential to improve pruritus. So I think both of them are being used for moderate in a scale of 4 to 6. Some patients with severe. But again, this is kind of a new good tools that we have available to treat those patients on top of that what we currently have. Dr. Goel, do you have any kind of suggestions about which one do we use between elafibranor, seladelpar, or do you use both of them for moderate itching?
I think that it's more is to come to see how effective both of them are in terms of the management of pruritus. I think when you really delve into the details of the response study for seladelpar and the ELATIVE for elafibranor, you can kind of tease apart based on the itch scores that they used, which drug had a much more met the primary treatment outcome for improvement in itch and which ones, was really seen in more of the secondary analysis. But these are small ends. Those are patients that they're analyzing that have moderate to severe itch at the entry of the study. So I think that as we start to use these medications more, we will start to understand a bit what the impact is on some of the PBC symptomatology.
I think, as you mentioned, I mean, looking at specifically at each clinical trial, just the phase 3 that was, those medications that were approved last summer, this is the ELATIVE study. You can see when in this kind of graph, the red graph is kind of the placebo, the blue is the elafibranor group, and you can see those patients who got drug can improve their itching up to 52 weeks. Again, there was different scales used, but again, both, medications, both elafibranor, both and seladelpar, which is kind of just the response, showed that, moderate itching showed some improvement. So again, we need more data. We need kind of long-term data to really look at to see if this is really going to be proved not only for a year, but actually kind of staying as a response for like more than a year. So, more data to be announced in the next couple of meetings from our societies. And then I think finally, I will kind of want to touch base about what's coming soon. We do have this really wonderful medications getting studied in phase 2 and phase 3 and hopefully being approved in the next kind of near future, called the IBAT inhibitors. And the IBAT inhibitors, in studies that I'm going to show, specifically Glimmer studies, show that different doses, these patients really show significant improvement in their itching. Their side effects, of course, because they inhibit the absorption of bile acids, diarrhea, and abdominal pain were the most common AEs. But there really no significant adverse events in both of those clinical trials. So I think the IBAT inhibitors will be kind of coming as a potential new tool to be used in the next, hopefully, year. And then we will have a really good amount of tools to actually both treat disease activity as well as symptom base in those patients with PBC. This is kind of the Glimmer study, and this is the Vantage study. One is the linerixibat, the other one is the volixibat, both really studying the presence of itching in patients with PBC. Can you, Dr. Goel, give me kind of, again, 4 or 5 kind of key points to take about how to kind of treat itching or how to look for itching in those patients with PBC?
I think that one of the most important things to do is to remember that itch is a symptom that we need to assess in each of our visits. So asking about it, using something that is visual for patients to demonstrate how bad is your itch on a scale of 0 to 10, something like a visual analog scale. And then just asking the question is, do you experience it? And remembering that we do have some things already that are in our toolbox for management of itch, and that includes some of the non-pharmacologic therapy, but also some potentially effective therapy like rifampin, sertraline, naltrexone. And I think importantly, especially in a patient that needs second-line therapy, so if you have somebody that hasn't had a complete response to ursodeoxycholic acid or doesn't tolerate it, and you need to think about second-line therapy, then you might, in a patient that has itch to begin with, you may be able to select the appropriate second-line therapy. It could sort of meet both treatment goals or really help you address both treatment goals. It could help the disease control itself and improve biochemical disease, but it can also potentially improve the symptoms of pruritus. So thinking about the PPARs, especially if you're going to use second-line therapy in a patient that has pruritus, is important to consider. That's really the take-home for this. There are other trials that are underway to assess IBAT inhibitors, so ileal bile acid transport inhibitors for the management of cholestatic pruritus and PBC, and I think we'll have more tools to use for these patients soon.
Again, I want to thank Dr. Goel for being part of this conversation. And again, I would like to thank you for being part of this Curbside consults on PBC management. Thank you so much.
Thank you so much, Dr. Bonder.
Thank you very much to Dr. Bonder and to Dr. Goel, and thank you to our listeners for joining in. For more programs like this, be sure to subscribe to the CCO podcast channel on your favorite podcast player. Thank you, and we'll see you on the next podcast soon.